Today we are here to present CCR by Department of Ophthalmology. I would like to invite our head of the department, Dr. Chaitanya Prakash Gupta sir, to introduce our department.
Good morning. Our department, first slide. Good morning, respected senior faculty members, colleagues, and dear students. Our department is equipped with state-of-art machinery and modern diagnostic tools. Our faculty is as per NMC norms. We have 2 professors, 2 associate professors, 1 assistant professor, 2 emeritus professors, and 4 senior resident. We have 5 seats per year in PG course, so total 15 PGs we have. Our department started since the start of hospital since 2001, and MBUS curriculum was started. In 2009, MS was started with 1 seat, and later on it is increased up to 5 seats. BSc, MSc in optometry also started later on, and PhD was also started in 2018. We have specialty clinics every day, like glaucoma, retina clinic, cornea clinic, squint and neuro-ophthalmology clinic, and also we started oncology and oculoplastic clinic. So we are proud to announce that recent we have a new subspecialty, oculoplasty or ocular oncology. So we also welcome Dr. Rolika Bansal in our department for this facility. We have almost all advanced machinery and instruments like slit lamp with attached camera and recording facility, OCT machine, optical coherence tomography, which analyze the retina in layers, Humphrey field analyzer, perimetry, Perkins tonometer, non-contact tonometer, A scan, B scan, ND arc lasers, and over OTF 2 microscopes with recording with camera facility, phacoemulsification machines, vitreoretinal surgery machine, and cryotherapy machine. You'll see as the graph shows our OPD is increasing every year. These are the few peaks of our department. Surgical load also increasing every year. We have facility to cataract surgery routinely we are doing daily basis, and also glaucoma surgery, lid surgery, ocular tumor excision, pterygium, corneal tear repair, and vitreoretinal surgery, including skull fixation IOLs and vitrectomy and retinal detachment surgeries. We have few achievements also in last year. The Dronacharya Award given to me in last international YOSI conference, FICO Award, paper presentation in various conferences, and we have done also eye cell implant in a very young patient to correct his refractive error. We have continuous community outreach programs like school camps and surgical camp, OPD camps also for health checkups, and awareness camps also. And in future we are have plans to set up refractive surgery setup, LASIK laser, resume keratoplasty services, as our one associate professor gone for keratoplasty training, pentacam machine, brachytherapy under ocular oncology services, and fellowship programs in different subspecialties. Thank you. Now I will invite Dr. Saloni to discuss the case further.
Thank you, sir. Thank you, sir. I, Dr. Saloni, Junior Resident of Ophthalmology Department, under the guidance of Dr. C.P. Gupta sir and Dr. Vineet Pradhan sir, will be presenting the CCR of a case of a 32-year-old female with blurring of vision and headache. A 32-year-old female resident of Jaipur, a corporate job employer, presented in ophthalmology OPD with complaints of blurring of vision in both eye and headache since past 4 years. She was asymptomatic 4 weeks back when she developed headache and transient blurring of vision in both eyes, described as graying out of vision for a few seconds, after which the vision return to baseline. The blurring of vision in both eyes were of insidious onset, progressive nature, painless, and lasted for 10 to 20 seconds. She also complained of headaches, which were continuous, dull aching, of moderate intensity, especially in the morning hours, affecting her ability to perform routine daily activities and relieved on medication. She had no history of redness, photophobia, flashes and photo on her visual fields, diplopia, fever, vomiting, neck stiffness, dizziness, head or ocular trauma. She has a history of similar complaints of episodes of transient blurring of vision in both eyes 2 years back. She went to other higher hospitals and was diagnosed with myopia and astigmatism, and corrective refractive glasses were given for the same. She goes for annual eye checkups and occasionally takes paracetamol tablets for headaches. She is a vegetarian by diet, has normal sleep cycle, normal bowel and bladder habits, and she's a non-alcoholic and a non-smoker. She has no history of diabetes, hypertension, hyperthyroidism, or tuberculosis. She has no history of similar complaints in her family. She attained menarche at the age of 15 years old. She has regular menstrual cycles, each lasting for 3 to 5 days, every 32 days, with normal flow. She's unmarried. To summarize, a 32-year-old female presented with transient blurring of vision in both eyes, headaches since last 4 weeks. She's a known case of myopia and astigmatism and has been using corrective glasses for the past 2 years. She has no history of any systemic illness and no history of using any topical medications. We performed a general physical examination and local examination. On general physical examination, the patient was conscious, well oriented to time, place, person. Her height was 163 centimeters, weight was 57 kgs, and her BMI was 21.45 kgs per meter square. Her temperatures were 36.1 degrees Celsius. Her blood pressure was 120 by 80 mmHg. Her pulse rate was 60 beats per minute, and respiratory rate was 12 breaths per minute. She has no signs of pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or peripheral edema. On her ocular examination, her unaided visual acuity was 618 and 612 in right eye and left eye respectively. Her best corrected visual acuity was 6.6 and her color vision was normal in both the eyes. Her pupils were on both direct and conjunctival right reflex were central, round, regular, reactive. Her ocular movements were full, painless, and present in all gazes. Her intraocular pressure was 14 mmHg, which is normal. On slit lamp biomicroscopy, her eyelids and eyelashes were normal, conjunctiva was normal and non-congested, and her anterior segments were within normal limits in both the eyes. So we performed a dilated fundus examination using an indirect ophthalmoscope and a 90D lens, which showed the media was clear, the glow was present, and the fovea was intact. She had a 1 to 2 diopter disc elevation and blurring of disc margin and obliteration of cup. She also has venous dilatation and tortuosity presence in both the eyes. So we took a fundus photograph. On the right hand side, you can see the normal right eye fundus compared to the left side, where the right and left eye fundus photographs are seen. We can appreciate the blurring of disc margin, the venous dilatation and tortuosity, and the obliteration of cup in both the eyes. Based on the general and local examination, the patient's best corrected visual acuity was near normal. The color vision pupillary reflexes were normal. The anterior segment and intraocular pressures were normal, but the fundus shows bilateral disc swelling with normal appearing posterior pole. Can anyone from the audience tell me the possible causes of disc swelling on fundus examination? Right. Anyone else? Pseudopapular. Okay. Let's discuss the differentials in details. We can rule out the central retinal vein occlusion, as yes, there will be disc edema, but the fundus findings will also include hemorrhages extending far beyond the peripapillary area. We can also rule out the anterior ischemic optic neuropathy, as there will be disc swelling, but initially the presentation will be unilateral. Since the patient has no history of diabetes, we can also rule out diabetic papillopathy. And from her general examination, we know her intraocular pressure was 14, which is within the normal limits, so we can also rule out the optic hypotonia. She has normal blood pressure and there was no history of hypertension, so we can also rule out malignant hypertension from the differential diagnosis of optic disc swelling. Let's discuss the most common causes further. In our patient, we know there was a bilateral complaint where the onset was insidious, gradual loss of vision was seen, and the disc edema was marked, all suggestive of papilledema. We used the Fresson scale for grading papilledema. In both the eyes, there was a C-shaped halo with a temporal disc margin sparing, so we graded both eyes with grade 1 papilledema. Next, the ancillary images. First, we did a spectral domain optic coherence tomography for imaging both the optic nerve head and the retinal nerve fiber layer. First, we did the optic spectral domain optic coherence tomography. Here we can see on the right side there is a normal report of an optic of a normal OCT optic nerve head, where we can see the exacted horizontal and vertical tomographic images. On the left hand side we can see the patient's finding, where we can see the characteristic lazy V sign. This lazy V or sleeping contour is formed by the subretinal hyperreflective spaces adjacent to the optic nerve head, appearing as dark pockets under the neuroretinal, appearing as a dark spots under the neurosensory retina, indicating the fluid buildup. Presence of these subretinal hyporeflective spaces are indication of the patient with papilledema. Next, we can see on the right hand side the normal OCT finding, OCT report of a retinal nerve fiber layer. We can appreciate the green zone, the yellow zone and the red zone. The green zone mark that anything present here will be present in 95% of the population as norm. The yellow zone indicates the borderline and the red zone indicates the any finding present here will be seen only less than 1% of the population. In the normal finding we can see the both eyes are almost entirely in the green zone, and in our patient we can see the both the right eye as well as the left eye is outside the green zone. Hence marking that there is the retinal nerve fiber layer thickness is increased. Next, we performed the perimetry. It detects the early visual field changes before any significant visual loss has occurred, aiding to monitoring and treatment progression. On the right hand side we can see a normal report of a normal visual field. Here the numbers represent the retinal sensitivity of that exact point. On the right hand side we can see this gray scale of the same data. Lighter the gray scale means more the retinal sensitivity, and darker the gray scale means that particular point is has less retinal sensitivity. In our patient we can appreciate that there's an enlargement of blind spot, and there's also an inferior nasal step present, which is indicative of early contractions of the peripheral visual fields. To summarize, on spectral domain optic coherence tomography there was a lazy V sign present, there was increased retinal nerve fiber layer thickness, there was automated perimetry. In automated perimetry there was enlarged blind spot, inferior nasal steps was present, all of which is suggestive of bilateral grade 1 papilledema. So to conclude, a 32-year-old female with blurring of vision and headache since past 4 weeks presented in our OPD. Based on the history and examination, we diagnosed the patient with bilateral grade 1 papilledema. Now both the headache plus papilledema are the signs of raised intracranial pressure, so we requested a neurological consult. Thank you. I would now like to invite Dr. Anush Jain to take the case further.
Thank you, Dr. Saloni, for your valuable input. Good morning, everyone. I am Dr. Anush Jain from the Department of Neurology. I would like to take the case further. So So this patient was referred to us in view of blurring of vision from both eyes and new onset daily headache with recent worsening. Characteristic of the headache was it was dull aching, holocranial of moderate intensity which worsened on supine position and was associated with blurring of vision from both eyes. On examination, the higher mental functions were normal. Mini mental state examination, patient scored 30 by 30. Cranial nerves, pupils were 2 mm equal and reactive to light. There was no relative afferent pupillary defect. Fundus examination showed grade 1 papilledema in both eyes. Extraocular movements were preserved. Rest of the cranial nerves were intact. Motor sensory cerebellar examination, there was no focal deficit noted and the neck rigidity was absent. So to summarize, 32-year-old right-handed lady presented with new onset daily headache associated with the following red flag clinical features, that is aggravation in supine position and blurring of vision from both eyes. So both of these signs were the features of raised ICP, and on examination we had grade 1 papilledema in both eyes. So based on the history and neurological examination, possibility of cerebral venous sinus thrombosis, space occupying lesion, chronic meningitis and idiopathic intracranial hypertension were kept. For further evaluation, MRI brain with venogram was planned and lumbar puncture with pressure monitoring was planned after MRI. The routine hematological examination was suggestive of hemoglobin of 9.7 gram per dl, MCV of 111 and MCH was 36. Now I would like to invite Dr. Hunisha from Radiology to describe the neuroimaging of the patient.
Thank you, Dr. Anush. The MRI findings of our patient were, on the left is an axial T2 weighted MR image at the level of globe and optic nerves demonstrating the distension of the optic nerve sheath. On the right is a reference image of normal appearance of bilateral optic nerves and bilateral optic nerve sheaths. On the left is a coronal T2 weighted MR image demonstrating increased caliber of bilateral optic nerve sheaths. On the right is a reference image of normal appearances of the same. On the left is a maximum intensity projection 3D phase contrast MR venography reconstruction image demonstrating mild narrowing of bilateral transverse sinuses laterally. These are axial and sagittal T2 weighted MR images at the level of globe and optic nerve showing loss of expected curvature of posterior aspect of right globe with flattening. Here is a sagittal T2 weighted MR image eliciting absence of partially or empty sella in our patient. To summarize, the following were our findings: narrowing of bilateral transverse sinuses, unilateral posterior globe flattening, bilateral optic nerve sheath distension. There was no space occupying lesion and no hydrocephalus. There was no evidence of meningitis as there was no sulcal hyperintensity on the plain scan. Hence, the above findings are in favor of diagnosis of idiopathic intracranial hypertension. Now I would like to call upon Dr. Anush to take this case discussion further.
So neuroimaging rule out the possibility of CVST and space occupying lesion. However, imaging features of idiopathic intracranial hypertension were present. For further evaluation, CSF examination was done after written and informed consent. So on CSF examination, CSF pressure was 76 centimeters of water. The CSF cytology and biochemistry were normal. Now both the neuroimaging as well as CSF examination were suggestive of IIH, but to confirm the diagnosis we applied modified Dundee criteria for idiopathic intracranial hypertension. So there are two separate criteria for IIH with papilledema and IIH without papilledema. Our patient had papilledema. Along with that, the other features, that is elevated lumbar puncture pressure, normal CSF biochemistry, neuroimaging to rule out any etiology, any disease of brain parenchyma, and normal neurological examination except for 6 cranial nerve palsy. So our patient fulfilled all the criteria, and along with that there were suggestive features of raised intracranial pressure on neuroimaging. Hence, after history ma'am, except for 6 nerve palsy. So 6 nerve palsy can be present. So based on the history, neurological examination, neuroimaging and CSF studies, we made the final diagnosis of idiopathic intracranial hypertension with papilledema. For the treatment plan, there are two options. First is medical management, second is surgical management. Medical management usually involves drugs like acetazolamide, topiramate, furosemide. Duration of therapy usually is 6 to 24 months. And medical management alone can result in remission of IH in 70% of the cases. Surgical management is indicated in case of fulminant IH, that is rapidly progressive vision loss or visual loss despite medical therapy. Surgical options include lumboperitoneal shunt, ventriculoperitoneal shunt, transverse sinus stenting, optic nerve sheath fenestration. In context to our patient did not have fulminant IH, so we started on tablet acetazolamide and topiramate in usual dosage, and the patient was asked to follow up after 2 weeks. Now I would like to invite Dr. Yashika to take the case further.
Thank you, Dr. Anush. Good morning, everyone. I'm Dr. Yashika Mathur, final year postgraduate resident. 32-year-old female with previous history of headache and blurring of vision. She visited other hospitals where she was given refraction, correction of the glasses and symptomatic treatment for pain relief. But her complaints remained persistent, for which she visited Mahatma Gandhi Ophthalmology OPD, where her detailed slit lamp examination and fundus examination was performed, suggestive of disc edema, which was confirmed as papilledema with idiopathic intracranial hypertension after consulting with Neurology and Radiology department. These were our findings from all the 3 departments: papilledema, IAH and CBC suggestive of anemia. What should be our next approach? Patient was managed conservatively by collaborative efforts of Neurology and Ophthalmology. She was kept on follow-up to check for progression of papilledema. Though the patient was diagnosed, her blood workup was suggestive of anemia. Since anemia is a risk factor for development of idiopathic intracranial hypertension, a hematology opinion became need of the hour. Now I would like to invite Dr. Vijeta, senior resident from Department of Ophthalmology. Thank you.
Thank you, Dr. Yashika. Good morning, everyone. I am Dr. Vijeta Niranjan, Senior Resident, Department of Clinical Hematology. So the hematology reference was taken in view of anemia in an adult female presented with complaints of bilateral blurring of vision and new onset daily headache. The complete blood count showed low hemoglobin of 9.7 gram per deciliter, that is moderate anemia, with raised MCP of 111 femtoliter and raised MCH of 36 picogram, while the TLC and platelets were within normal limit. This is the advised peripheral blood film. From the resident, can anyone tell us the findings on the PVF? So this is the another picture.
So any medicine residents there? So patient of anemia, RBC size is high, MCV is 111 and a PBF like this. What will you think of? Perfect.
So this was the peripheral blood film that showed the macrocytic RBCs. So to compare the size of RBC, this is the lymphocyte, the nucleus of lymphocyte. We take the nucleus of lymphocyte for comparison for the RBCs. So these are the macrocytic RBCs with the mild to moderate anisopoikilocytosis in form of teardrop cells, in form of macrovellocytes. The total leukocyte count was normal and the differential showed the hypersegmented neutrophils. You can appreciate these are the hypersegmented neutrophils having lobes more than 5, while the platelet counts were normal on the smear. There was no any hemoparasites or abnormal cell was found on the peripheral blood film. This is the another high power view. This is the hypersegmented neutrophil having lobes more than 5, and these are the macrovellocytes. So the impression on the PVF was made as macrocytic anemia. So the differential diagnosis of macrocytic anemia can be of megaloblastic and the non-megaloblastic. According to the history, this patient not having any prolonged history, not taking any medicines, so most of the cases of non-megaloblastic anemia were ruled out in this case, and the likely differential was the megaloblastic anemia. So we further advised the other investigations that showed low serum vitamin B12 level of 150 picogram per ml with a raised LDH of 1240. The retic count was within normal limit, the parietal cell antibodies was negative, and the LFTs were within normal limit. So on the basis of the history, the peripheral blood findings and the other investigations, the diagnosis we made as the macrocytic anemia due to B12 deficiency. And we started her on the B12 supplementations, initially with the injectable and followed by the oral supplementations for 3 months, and we asked to follow up after 3 months. On 3 months follow up, her hemoglobin showed significant improvement and her MCV and MCH was also normalizes. Now I would like to invite Dr. Yashika to take this.
What was the cause of B12 deficiency? There has to be a reason, no?
So in this
was it nutritional? Was
yes.
it intestinal parasites?
Sir, since she is vegetarian by the diet, so most likely the cause is nutritious. And sir, to rule out the because she is female and adult, so we also advise for the parietal cell antibody to rule out the autoimmune cause that was negative in this case. So most likely it is due to dietary deficiency only.
So when you conclude your diagnosis, you have to mention the cause of the potential possible cause of the deficiency.
Yes. Thank you. Now I would like to invite Dr. Yashika to take this case forward.
Thank you, Dr. Vijeta. Hematology evaluation was suggestive of megaloblastic anemia. Patient was managed for the same. We asked the patient to come on follow-up after 2 weeks in all the concerned departments of ophthalmology, clinical hematology and neurology. On 2 weeks follow-up, there were no vision-related complaints. Headache was symptomatically better and there were no fresh complaints present. On 3 monthly follow-up, we repeated her assessment. Her both eye best corrected visual acuity was improved to 6.6 from 6.9. Rest findings were within normal limits. On fundus examination, both eye disc was slightly paler on the temporal side and vessels were mildly tortuous. Rest findings were within normal limit. Mostly when we diagnose whenever a patient come to us with anemia, this is a fundus picture of post-treatment reports. The first picture is from August and the other picture is from October, and we can see a significant significant difference and improvement in a fundus photograph. Ophthalmic findings in anemic patient. In anemic retinopathy, retinal tortuosity is seen in severe anemia, and dot blot hemorrhages, flame-shaped hemorrhages, cotton wool spots and rod spots are seen. But in our patient, none of these findings were seen, so we ruled out anemic retinopathy. This is the perimetry that we performed after 3 months. Previous visual field examination showed a slight enlargement of the blind spot and inferior nasal step. On follow-up, repeat visual field testing demonstrated improved peripheral vision with resolution of the inferior nasal step and regression of the blind spot enlargement. This is our OCT for follow-up. Comparative OCT images shows a reduction in the lazy V sign, indicating resolution of the fluid that was previously elevating the optic disc. This article from American Journal of Ophthalmology quote that these investigations are performed worldwide for evaluation of suspected case of IH and disc edema. We performed an additional investigation, that is electroretinography. This is a newer modality used to assess retinal function. ERG was undertaken in this patient to evaluate for any retinal pathology that may not yet be apparent on the fundus examination. Her electroretinogram was normal. Before concluding, we discussed the literature of idiopathic intracranial hypertension. So before concluding, we discussed the literature of idiopathic intracranial hypertension and discussed its risk factors. This epidemiology of rise in IH cases from year 1990 to 2025, the global incidence of IH has been increased from this period of time due to better detection modalities and lifestyle changes. What is idiopathic intracranial hypertension? Why do we call it idiopathic? And what are the risk factors? And what can be the possible management? Raised intracranial pressure, unknown cause, causing severe headache and visual problems. Why do we call it idiopathic? Conditions arises without a known or identifiable cause, although there are various risk factors, the interplay of which can precipitate IAH. To be called IAH, other identifiable causes of increased ICP must be excluded. These are the risk factors. In context, obesity, female gender, medication and substances, associated medical conditions. In our patient, we ruled out anemia. In context of our patient, the routine workup shows megaloblastic anemia and no other risk factor could be identified for idiopathic intracranial hypertension. This article states the most commonly IAH is seen in iron deficiency anemia, but it has also been reported in patients with megaloblastic anemia, irrespective of gender, male or female. Patients with megaloblastic anemia should be evaluated for IAH and vice versa. Approximately 1 of every 5 patients with IAH has anemia, and this is severe in more than 10% of patients. Given high incidence of anemia and availability of a complete blood count, we recommend that this test should be obtained for all patients with suspected IAH cases. As per study, 8.1% individuals having IAH were diagnosed with megaloblastic anemia. Our aim is to address the cause of raised ICP, conservative management and lifestyle modification to take in charge against raised ICP. In case of severe vision loss, we opt for surgical management. Optic nerve fenestration is an ophthalmic surgical intervention via medial transconjunctival route when the medical management is not sufficient. Patients with idiopathic intracranial hypertension are typically managed medically by neurology and ophthalmology services. However, due to availability of a multidisciplinary approach team at our hospital, we were able to comprehensively evaluate the underlying cause and provide definitive treatment for the patient. I would now like to invite Dr. Vineet Pradhan sir to provide insights of this case. Thank you.
Good morning to the distinguished dignitaries and students. I am Dr. Vineet Pradhan, Retinal Consultant of Department of Ophthalmology. So as we were discussing right now, maybe from the steps of the procedures what we think, it looks to be very normal that a patient with headache, with blurring of the visions comes to IOPD and the fundus shows the schedema, the next step is neurology, the next step is this. So this is the normal thing, but the important thing or our point of presenting is the atypicality of the case, because most of the time this patient is not a novice patient. She visited multiple places, good centers with the same complaints, but there it was only a myopic view which was taken in the management, that eye was seen, refraction was given, symptomatic treatment was given, and it was sent off. So this is the importance of a multidisciplinary approach for treatment of any patient, not like this, but any patient. That was our point of presenting it as this. So today we are sitting in the zenith of modern medicine, having accumulated the wealth of knowledge and information from the experience of human civilizations. We have today advanced diagnostic technologies ranging from simple blood tests to gene probes, scans, cameras, improved therapeutic agents and robotic hands to deliver not only the accurate but pinpoint treatment to our patient. But as we advance but still we are faced with the newer challenges of plethora of diseases patterns. Many may be atypical, not heard of. Our case represents one such case. The atypicality of the case and our approach undermines the need to develop an approach in our inquisitiveness and thinking beyond the obvious in our practice and our teaching practices also, so that our outgoing medical graduates, the Indian medical graduates as desired by NMC, they are more what I gave as acronym for that is CELS positive, means competent, ethical, leadership quality, lifelong learners with scientific temperament. So in our teaching program also they should be oriented to see beyond the patient and in a holistic way. So as this case summary told that it was a 32-year-old female presented in the ophthalmology department with blurring of the vision, complete ophthalmic examination and multidisciplinary approach involving neurology, radiology, hematology, evaluation and revealed the final diagnosis of atypical presentations of IIH in a case of megaloblastic anemia. Again, in a megaloblastic anemia, and we saw the incidence, 90% of the cases with IIH with anemias are iron deficiency anemias. But megaloblastic anemia forms only 5 to 10% of the cases. Even if we see the vitamin B12 level, they are not grossly reduced. So just ordering for a vitamin B12 level does not correlate to the vitamin B12 deficiency. So the methylmalonic acid and the further investigation is required for going down to the root cause of the disease. And the literatures and the possible pathology which is discussed in the literature is that it is not only the size or the level of the anemia, it may be some metabolic syndromes which is associated with the vitamin B12 deficiency and the metabolic changes that may be the cause of the IIH. So this case exemplifies the importance of thorough evaluation of a known and other possible pathologies of any disorders of keeping high index of suspicion. This is one thing which when we were graduate, keeping high IOS is very much recommended. Today iOS for modern generation is an operating platform for Apple. They say it is iOS, so it is operating platform, but for medically it is high index of suspicion should be kept, not only depending only on the reports, only on the documents what we are seeing in front. So history tells us that in 1687 one man thought out of box and we got the basis of science, Sir Isaac Newton. In 1876 one man tried beyond typical and we got telephone, Alexander Graham Bell. And in 1905 one man challenged the established thought and we got E is equal to mc square, Isaac Newton. And similarly in 1982 one man thought slightly away from the routine and we are sitting here, Dr. M.L. Sonka. So if we go out of the normal routine thinking and all, we may apply our thoughts and inputs for betterment of the patient as well as the society. So we acknowledge the invaluable contributions of multidisciplinary team whose coordinated effort enable timely diagnosis and appreciate treatment of the patient. In this case also, as Sir has already discussed, that Diamox medical management and initial line of therapy has started, but every treatment has got its side effects and that depends on the duration for which the treatment is to be given. So Diamox how long? Lifelong? 32 years of age till 100 years of age with associated side effects and all those things. So how long we have to increase? Report says that if we treat the cause, especially like anemia and megaloblastic anemia, after stopping of this symptomatic treatment for IIH, the thing does not recur. So we have kept the patient under observation. After stopping the Diamol, we'll see after 6 months whether the edema or field changes or any ophthalmic presentations recurs or not recurs.